So for this video, we're going to begin our discussion of passive accessory motion testing of the hip. Now recognize this is a very stable, large joint, and so the amount of force is going to be considerable. As such, you need to be mindful of body mechanics and your setup for each one of these. We're going to break this down into 3 videos. The first one, that is this one, is going to be where we look at distraction as well as long axis traction. And so for this, we're going to set our patient up in a supine position. Now, there's a couple variations that can take place from here. One such is actually that you would provide a belt or a strap across the individual's pelvis to create some stabilization and allow them to not slide or move on the table as you're providing force in kind of this caudal direction. For this video though, we're going to keep things simple. I'm going to show you most of these just with my hands. So we're going to begin with our reference limb being the left limb. And we'll start with long axis traction. Now, in order to do long axis traction, you need to have already completed a screening of the lower extremity, as you're going to provide force not only through the hip, but also the knee and foot and ankle. This is not only an assessment technique, but with any of these passive accessory motion tests, they also can be treatment. And so long axis traction would look like this. You're going to be at the foot and ankle. I find that if you use the palms of your hands as references, those can kind of encapsulate both the medial and lateral malleoli. You can interlock your hands behind, kind of at the level of the Achilles tendon. And then from here, all you really need to do is lean back. So I'm in a little bit of a staggered stance position. All I'm doing is leaning back. And when I see that my patient begins to move just a little bit on the table, you can see that actually all the way up at the head and neck, I know that I'm providing sufficient traction. Now this can be a static assessment. You can also move through different ranges of motion and provide that long axis traction. It can also be treatment-based, and so oftentimes what I will do with patients is I'll provide a slight oscillatory technique with this as well. That looks like this. You also can provide this through a range of motion to help with regards to relaxation, as well as if there's any tonicity that the patient is holding. Oftentimes, you can go back and forth between traction as well as relaxation, and many patients report this actually feels quite good and relaxing. Additionally, we can look at distraction more specifically of the hip joint itself. For this, we're going to bend our patient's knee up, and we're going to come right next to them. Now, to show this a little easier, I'm going to do it on the opposite side so you can visualize it, but if we were staying on the left limb, this would be our position. So, after we bend our patient's knee up, we can come right alongside them, and our hands are going to be placed really right at the hip joint. Now, some individuals will keep the knee bent here. Some individuals will also allow the individual's kind of calf to rest on their shoulder, and thus they can get in a little bit closer to the hip. Now, keep in mind, as we get into the hip, we're starting to get into an area that is more private for most individuals. And so if there are some gender variances here, for example, if you're a male therapist working with a female or a female therapist working with a male, make sure that you're practicing safe techniques, and you're also protecting the identity of the patient as well as yourself. So explain what you're going to do, get permission from the patient, and then proceed. We're going to come right at the hip joint. This more medial portion of my hand, hypothenar eminence, is going to go as close to the joint as I can, and then I'm going to be distracting the hip in a caudal direction. Right? So from this position, we're going to provide that distraction. We can either hold it statically, or we can also use a bit of an oscillatory technique or kind of intermittent technique. With all of these, we want to ask the patient, is this producing our comparable sign? Is it alleviating? And so one way you can do that is simply by saying, with this technique, I'm interested if it's better, worse, or no different. And so it would look like this. better, worse, no different. Patient may give a response that it's alleviating or that it's actually worsening. Okay? So, 2 techniques, long axis traction, as well as distraction more specific to the hip joint itself. This is part 1. Have a go with a peer or colleague, and let me know if there's any questions.